Okay, today I want to take a few minutes to at first talk about the heart disease epidemic and then discuss some non-modifiable risk factors, things that we really can't do anything about, modifiable risk factors, things that we can do something about, and of course, leave some time for questions at the end. And interestingly, between the years 2000 and 2011, heart-related deaths actually gradually declined on an average of 3.7% per year, which is fantastic. That mortality level kind of leveled off between 2011 and 2015. And for the first time since 1969, heart disease mortality increased from 2015 and continues to do so. With that in mind, 1 in 4 deaths in the US are from cardiovascular disease. That's 647,000 deaths each year, and that amounts to 1 death every 49 seconds, which is just absolutely too much. There are 735,000 heart attacks every year, and all of this heart disease is leading to an increased incidence of congestive heart failure, and that's up to 1 in 500 Americans suffering with this malady. The current healthcare costs to pay for all of this, of course, is astronomical, currently estimated at $318 billion per year. And of course, that's only estimated to rise. Let's talk a minute about our non-modifiable risk factors. These are things that we can't really do anything about, right? Men, there's nothing we can do about being men. And there's nothing we can do about our aging. But men over age 45 and women over age 55 are at an increased risk. In women, that estrogen provides some protection from heart disease, but unfortunately, diabetes in women puts you at higher risk than diabetes in men. African Americans are at the highest risk, followed by Caucasians, and then Hispanic Americans, and then Asian Americans. And of course, well, there's nothing we can do about our family, right? Family history, unfortunately, can lead to an increased risk of cardiac events in the future as well. I don't want to spend too much time talking about things that we can't change. Let's take some time to talk about things that we can do something about, right? And those are our modifiable risk factors. And there's a lot of them, right? There's a lot that we can do, a lot that's in our own power to have control over. And we're going to talk about each of these. And so first, let's kind of talk about some healthy habits. And I think all of that needs to start with physical activity, daily exercise, right? The Department of Health and Human Services recommends that healthy adults should exercise 150 minutes of moderate intensity every week, or 75 minutes of vigorous aerobic activity, or a combination of the two each week. All right, so what is moderate intensity? What does that mean? Ultimately, moderate intensity exercise would be things like walking briskly, swimming, golfing, no cart, right? Doing yard work, gardening, walking the dog, getting up and moving about. And that 150 minutes comes out to about 30 minutes per day, 5 days per week. Vigorous intensity exercise would be things like aerobics, cycling, jogging, things that are really going to make you break a sweat. And of course, this can be a little bit intimidating, right? I mean, 30 minutes per day, 5 days a week. However, what some recent studies have shown is that you can break that time up. You can take that 30 minutes per day, break that up into 10-minute sessions, and that's been proved, 3 10-minute sessions, and that's been proven to be just as effective as if you worked out for that entire 30-minute time period. And of course, we know that this has benefit, right? Here on this graph, I'm not sure if you can see my little cursor there, but I don't think you can. Along the left axis, we've got risk of death, and on the bottom, we have differing amounts of exercise capability. METs, or metabolic equivalence, is the amount of exercise that you can do. So you can see the lower amount of exercise you can do, the higher your risk of death is. The more exercise you can do, the lower risk of death, which is intuitive, right? The more physically active, the better in shape you are, the longer your life is going to be. And you might say, well, you know, I've got my smartwatch and I'm counting all of my steps. What about this goal of 10,000 steps? Well, unfortunately, there's actually been no big scientific studies looking at the benefit of these 10,000 step goals. In fact, where this came from is all the way back in 1964 at the Tokyo Olympics. One of the very first pedometers were invented, and this pedometer had the ability to count, you guessed it, 10,000 steps. And that's where this idea of getting 10,000 steps per day came into play. Now, it's not to say that this 10,000 steps goal is not a good one. It certainly is. However, it may not necessarily be achievable for everyone. In fact, it's probably, one, not enough for young folks, right? Children, they need to be doing more than 10,000 steps per day, right? They need to be running, skipping, jumping, climbing all over the place to keep themselves healthy. And 10,000 steps may not necessarily be attainable for those that have chronic disease or disabling arthritis or other things that keep them from moving. And so it can be challenging, and when it's challenging, it can certainly be discouraging. And so instead, this idea of 30 minutes per day, 5 days a week, that's individualizable, attainable, and efficient. All right, what about tobacco, right? Gone are these days, right? Give your throat a vacation and smoke a fresh cigarette as advertised by your local docs, right? Now, we of course know this is a no-go, right? Smoking or using tobacco of any kind is one of the most significant risk factors for developing heart disease. In fact, 30% of heart disease is traced directly back to tobacco abuse. There's chemicals in tobacco smoke that can damage the heart arteries and lead to plaque formation. Carbon monoxide, right? Carbon monoxide replaces oxygen in your blood and can lead to hypoxia or low oxygen saturations. The trouble with this is no amount of smoking is safe. But the more you smoke, the greater your risk of heart disease. The good news is that the sooner you quit, the sooner you're going to reduce your risk of heart disease. And I love this graphic here. We'll just go through it quickly. 20 minutes after smoking, your blood pressure is going to return to normal levels. 8 hours after quitting, carbon monoxide is cut in half in your bloodstream. 3 days after quitting, you're going to start breathing a whole lot better. 2 months after quitting, circulation improves and your lung function can increase by up to 30%. 1 year after quitting, your risk of heart attack is cut in half. 5 years after quitting, your risk of stroke is reduced to that of a non-smoker. 10 years after quitting, your risk of lung cancer is reduced to that of a non-smoker. And 15 years after quitting, your risk of heart attack is reduced to that of a non-smoker. And so you can see here, time is of the essence, right? The earlier, the better. If you quit at age 30, you're going to add 10 years to your life expectancy and on. Thankfully, there are lots of quit aids. There's lots of support that's available. The Utah Quit Line has quit coaches that are available that can develop a personalized quit plan for you and help discuss different medication options that are available. The time is now. All right. Now, what about vaping, right? Isn't that so much safer? I don't have to explain to you guys, the use of vaping has significantly increased since 2008. Some troubling statistics here. 1 in 20 middle school age students, right? These are our 10 and 12-year-olds have reported use, and that's an 8-fold increase. In 2019, almost 30% of high school age students had used e-cigarettes, and that was up 10% from 2018. And unfortunately, this is only expected to rise. Here in Utah, the Utah Health Department expects that there's 38,000 teens that are actively vaping. And unfortunately, this is often not necessarily keeping them from tobacco, but a gateway to future tobacco use, right? Ingredients in these vaping products include things like nicotine, flavoring, propylene glycol, glycerin. All of this kind of looks fairly innocent. However, you're not ingesting those things, right? That e-liquid is heated to high temperatures. And during that time, toxic chemicals are formed like formaldehyde, acetaldehyde, and acrolein, right? Does anyone know what formaldehyde's for? Embalming dead bodies, right? And this is what we're ingesting and putting into our lungs. And so unfortunately, these are not as benign as they're being advertised. And despite their advertisement of these vaping products being listed as low nicotine, they've actually done some studies. And what they've looked at is they've used these low nicotine products and then tested the amount of nicotine that was in the saliva and in the blood compared to conventional cigarettes. And guess what? It's the same amount, right? Because in the end, the amount of nicotine in your body has nothing to do with how much nicotine is in the product itself, but how much nicotine you ingest. And so for folks who are used to a higher degree of nicotine, they're going to hold that drag in longer. They're going to take a deeper drag, which ultimately leads to higher levels of that nicotine despite whatever's in the product. And unfortunately, like I said, vaping is not necessarily preventing people from smoking, but ultimately leads to it's a gateway to smoking later on. And what about marijuana, right? Okay, it's recently legalized here in Utah for folks who are struggling with chronic pain. Now, one thing that's important to point out here, marijuana is not just THC, right? THC is the drug part of it, but marijuana itself contains almost 500 compounds, including 7 cannabinoids, right? Marijuana, so a lot of people might say, oh, well, marijuana is natural, right? But marijuana rarely arrives in this organic form, right? It's a plant just like your peaches in your backyard. It's got to be protected from insects and fungus, and so there's lots of sprays and chemicals that are sprayed all over the top of that in order to, keep it clean. And then combustion of that marijuana, just like combustion of that vape, leads to creation of new compounds like acetaldehyde, ammonia, benzene, carbon monoxide, cyanide, and other polycyclic hydrocarbons. And so in the end, just because it's a plant and organic doesn't necessarily make it safe. And so what does the research say? Well, unfortunately, there's not been very much research about marijuana because it's been illegal, right? There haven't been a lot of those clinical trials looking at how safe it is. Now, we do know that cannabinoids raise the resting heart rate, right, and can dilate blood vessels. This is going to put extra stress and strain on the heart by making it pump harder and faster. In fact, those with coronary artery disease are prone to developing chest pain after smoking marijuana. And the risk of heart attack is several times higher in that hour after smoking marijuana than it would be normally. There's lots of different things that are believed to be contributed to this. As you can see on this little graphic, right? So beyond the hazard of the chemicals that come with it, it can have effects on the platelets within our blood, which form clots. It can have actual oxidative stress, putting extra acid within our cells. It can produce arrhythmias and ultimately cause cardiomyopathy. And so, unfortunately, it's just not safe from a heart perspective. And so then, well, what about cannabidiol oil, right? The CBD oil. There have been some limited studies about CBD oil, and there is some possible cardioprotective effects there. They think that comes from the anti-inflammatory and the antioxidative effects of the oil. Some possible benefits, again, these are possible because unfortunately there's been no big studies, and they've seen perhaps a reduction in infarct size after folks who've had a heart attack, some increased blood flow after a heart attack, reduction in vascular damage from diabetes, and reduction in heart failure in patients with diabetes. And though usually well-tolerated, CBD oil can cause some other side effects like dry mouth and diarrhea, reduced appetite, drowsiness, but usually it's fairly well-tolerated. And I think one important thing to point out there is while the presumption is that CBD, the cannabidiol oil, does not have THC, that's the drug. There have been some studies that have shown that CBD oil can have some THC in it. And if it does have some THC contaminant, that can trigger positive on a urine drug test. And so you got to be careful with your formulation. All right, what about healthy eating, right? Unfortunately, there is no magic diet. However, there are certain diets that are good examples of healthy eating, like the DASH diet or the Mediterranean diet. In fact, I've heard some people say that the Mediterranean lifestyle, along with that Mediterranean diet, is good for the heart. In short, though, we want to eat more fruits and vegetables, whole grains, low meats, and low-fat dairy products, and we want to limit the bad stuff, sugar, salts, fats. All of this is no surprise to you. Sources of those healthy fats are things like avocado, certain nuts like walnuts and almonds, and olives and olive oil. And I wanted to kind of illustrate the changes that have happened, right? We see this food pyramid there on the left. I certainly remember learning about the food pyramid in school, and I love the foundation of this pyramid, right? The foundation of any good pyramid is bread, right? Bread, cereal, pastas, all the things that we love so much, followed by fruits and vegetables. And of course, there's even a teeny cap there on top for things like sweets. Well, unfortunately, all of this went out the window, and we have the new food plate, as you can see there on the right. And you can see, well, unfortunately, bread's got a demotion, right? Instead of the breads forming the foundation of our pyramid, now they only take up a quarter of our plate. Fruits and vegetables now should fill half of our plate. And, well, where did the sweets go? Well, unfortunately, they're off the plate entirely. All right, okay. What about sleep? The amount of sleep has impact on our risk of obesity, blood pressure, heart attack, diabetes, and depression. In fact, interestingly enough, 82% increased risk of heart disease if you sleep less than 5 hours, and a 60% increased risk of heart disease if you sleep more than 9 hours. So ultimately, pick someplace there in between 5 and 9, and you're all good. And what about sleep apnea, right? A lot of people think, oh, sleep apnea, that's just a problem in the obese. But unfortunately, the obesity is not the common denominator there. Thankfully, we have easy treatments with what's called CPAP, or continuous positive airway pressure. So let's talk a minute about what obstructive sleep apnea does, why we care, and its effect on the heart. Ultimately, what happens when we lay down, there's a propensity for our airway to collapse. And when our airway does collapse, right, we're asleep, and so we have no idea that this is even going on. As that airway remains closed, the oxygen saturation within our blood tanks. Our brain can sense this, and our brain says, whoa, 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 what's going on? Our oxygen levels are going low. You got to wake up. Right? And we wake up just enough to open that airway, take in some of that, breaths and oxygen, and then we kind of go back into sleep. And this kind of repetitive sleep, waking up and sleeping, waking up and sleeping, we never get into that deep restorative REM sleep, right? And so again, here on our graphic, we can see as that airway becomes obstructive, our oxygen saturations go down, our arousal, we don't quite get into that deep restorative sleep, and the pressures within our chest increase. All of that leads to extra strain on the brain, leading to a 60% increased risk of stroke. It puts extra stress on our heart, which leads to an 140% increased risk of heart failure and a 30% increased risk of heart disease. In fact, obstructive sleep apnea goes hand in hand with atrial fibrillation, right? We've heard about AFib, all of the troubles that come along with that goes hand in hand with sleep apnea. As we treat sleep apnea, the control of atrial fibrillation becomes much easier. All right, what about weight, right? A lot of what we've talked about so far, exercise, eating right, getting enough sleep, have direct impact upon our weight. And so what's a healthy weight? What should we strive for? And ultimately, there are a number of different measures, right? We can look at our BMI, we can look at our waist circumference, we can look at waist hip measurement, and there are differing goals depending on if you're a man or a woman. But as you can see, none of these really are a one size fits all. In fact, during our recent application for disability insurance, they wanted all three of these, as components to kind of ensure that my body composition was what it's supposed to be. The good news is that if you do a little weight loss, right, 3 to 5% weight loss can lead to dramatic declines in your triglycerides and your blood sugar. A weight loss of 10% can dramatically decrease your blood pressure and your cholesterol. And of course, how do we get there, right? Same things we've talked about: moving more, eating less, and getting enough sleep. What about alcohol? So if you choose to drink alcohol, it's better to do so if you do so in moderation. So what's moderation, right? For women of all ages and men over 65, the American College of Cardiology and American Heart Association would say that 1 drink per day is healthy. For men under 65, 2 drinks per day is heart healthy. And so what's 1 drink? So that'll be 1 can of beer, 5 ounces or 1 glass of wine, or a 1 ounce of your 80 proof distilled spirits. And I think that it's important to point out, right, this is 1 glass of wine per day or 1 can of beer per day, not all saved up for the weekend, right? We want 1 glass per day. And at this level, the theory is that this is protective to your heart. Unfortunately, at higher alcohol consumption, it can lead to damage to the heart, specifically alcohol-induced cardiomyopathy. All right, stress. It's inevitable. We all live very busy lives, and it goes without saying that stress can lead to maladaptive coping mechanisms like overeating, overdrinking, smoking, illicit drug use. And so all of those things are going to be further detrimental to our heart health. And so I would recommend that in the circumstance where there is stress, because unfortunately there's nothing we can do about that, that we look at other more positive coping mechanisms, such as deep breathing, relaxation, meditation, exercise. All of those things are going to help distract your mind from the stress of the moment and be able to refocus so that you can not only deal with that stressful circumstance better, but also help your heart out in the meantime. I just wanted to take one brief second and talk about COVID and the heart. Unfortunately, COVID has absolutely changed our way of life over the last year. In fact, the best thing this talk is to wear this mask. We know that COVID can be, absolutely awful on the lungs. But the more and more that we learn about it, it actually has strong effects on the heart as well. I've personally taken care of patients here in the hospital with COVID-related arrhythmias, specifically those with bradycardia, slow heart rates, and atrial fibrillation. I've cared for folks that are way too young, coming in with heart attacks as a consequence of the microthrombi that form in the vessels. And unfortunately, as they do have cardiac events, that's going to lead to increased risk of heart failure. I saw a study yesterday that said those that had severe COVID had up 40% of those folks that had severe COVID had myocardial injury noted on MRIs of the heart. So time will only tell to see what damage COVID really has done to those in our heart population. Let's talk a little bit now about some screening, right? These are some things that we need. So far, we've talked about things that are in our own power, things that we can do at home. And these next few things, these are things that we need the help of a doctor, all right? And so let's first talk about blood pressure screening. These got an update here in 2017. The American College of Cardiology and the American Heart Association got together, and this is a very busy algorithm here, but ultimately it illustrates the changes that have been made. Ultimately now our goal for most of the population would be to have a blood pressure of less than 120 on the top and less than 80 on the bottom. As we become a bit more mature, we do get a little bit more lax in these guidelines, but ultimately these are the ones, the benchmarks that we're comparing to. Now, if you've got a blood pressure above 120, you fall into this elevated blood pressure category. And at that point, we really ought to have a conversation about lifestyle changes, things that you can do to reduce your blood pressure, like weight loss, limiting salt, exercise, all of those things to help lower the blood pressure. Once the blood pressure is over that 130 range, 130 to 139, we're talking about non-pharmacologic therapy as well, weight loss, salt restriction, but now thinking about adding blood pressure medications. And certainly if your blood pressure is over 140 or over 90 on the bottom, we're talking about blood pressure medicines. This is a little bit of a busy chart, but ultimately what this shows is that while the amount of people who were recommended pharmacologic therapy didn't necessarily change, it did show that with these changes in different buckets, that more people are not at goal as far as the management of their blood pressure. And so certainly there is work to be done. Screening for high blood pressure should begin at age 18 and should occur at least every 2 years. We've talked a little bit about non-pharmacologic therapy, things that you can do. Weight loss, you get approximately 1 point drop in your blood pressure for every kilogram lost. The DASH diet led to approximately 11-point drop in your blood pressure. Sodium restriction led to a 5-point drop in blood pressure, and exercise led to a 5 to 8 point drop in blood pressure. And so for a lot of folks, initiation of these type of non-pharmacologic therapies may be enough to keep you off blood pressure medicine entirely. For those other folks that can't quite get there, there are tons of medications to choose from. First line medications are things like lisinopril, losartan, hydrochlorothiazide. These are generic medications that are available and cheap. And then there are lots of other second line medications like metoprolol, carvedilol, amlodipine, diltiazem, tons of medications, all to get us and get our blood pressure under control. Let's talk a minute about cholesterol. In 2018, again, the American Heart Association and the American College of Cardiology got together and updated the previous 2004 guidelines. And I want to talk just a minute about, first off, why do we even care about cholesterol, right? So I've got a little blood vessel here. We can see happy little red blood cells traveling on to wherever they need to be. Let's just say in this moment that this blood vessel is going to our brain, right? And as a consequence of cholesterol out in the blood, we can develop plaque, right? And beyond just cholesterol, right, there are lots of things that are coming together to develop this plaque. But inside of that plaque is, you can see lots of cholesterol and inflammatory cells. And as that plaque grows, both into the vessel and out of the vessel, it leads to narrowing. Our blood pressure is pelting against that thin cap with every heartbeat, such that there's a possibility that it could break open. And if it were to break open, well, you could see that it could block up the entire artery. And if it blocks up the whole artery that goes to our brain, well, that's a stroke, right? If it blocks up the artery that goes to our heart, that's a heart attack, right? And what they found is that cholesterol medications, while they do have effect on the blood cholesterol, it also has beneficial effect on the plaque cholesterol. And so what else can we do? Aspirin, of course, helps prevent that little clot from forming, and cholesterol medications, in addition to their effect on blood cholesterol, also help prevent plaque from forming, shrink existing plaque, and stabilize existing plaque. So let's just take an example here of this 60-year-old gentleman. He's 69 inches tall, blood pressure a little bit on the high side, 144 over 86. He's not on any medications. He's a non-smoker, no family history of coronary disease. And here we've got his cholesterol panel to look at. His total cholesterol is 195. That's less than the 200 range. His LDL, or his bad cholesterol, is 125. That's less than the top end of normal at 130. His HDL cholesterol, or his good cholesterol, is 50. That's above the the normal range for good cholesterol. We want that above 40. And his triglycerides are 100, well below the upper limit of normal at 150. And when we take his risk factors and we calculate out where his risk would be, previous guidelines would say that he's really not recommended to be on cholesterol medication. And so with this new update, we get the new update was made to help focus their use of cholesterol medications a little bit better. Previous guidelines were based largely upon blood cholesterol levels with specific targets of where we should get the cholesterol numbers to. However, we know that there are lots of patients who have normal or even borderline elevated blood cholesterol who are still having heart attacks and could benefit from statin therapy. And so the new guidelines recommend the use of this calculator. And you can see, in addition to cholesterol numbers, we're also taking into account blood pressure, diabetes, tobacco abuse, age, gender, and race, and unfortunately not family history, which plays such an important role, but we're getting there with this calculator. And ultimately, what the recommendations would show is that if your risk, your calculated risk, is 7.5%, and what I mean by that is if your 10-year risk of having a heart attack is 7.5 risk or higher, then we ought to consider cholesterol medications to reduce that risk, right? For those that have a risk between 7.5 and 20%, our goal is a 30% reduction in the LDL. For those that have a greater than 20% risk, we look for a 50% reduction in LDL. For our folks that have diabetes, all patients should be on at least a moderate intensity statin. And if you have higher risk, above that 7.5% risk, then you really ought to be on high doses of statin. What we found is that folks who have diabetes have coronary artery disease. And so we need to be a bit more aggressive with those folks. If you have a known diagnosis of coronary artery disease, you need to be on a high intensity statin, again with the goal of reducing LDL or the bad cholesterol by 50%. And there are a number of populations that honestly we don't do well enough in managing. Those folks who have metabolic syndrome with chronic kidney disease, rheumatoid arthritis, HIV, or history of preeclampsia or premature menopause. All of these folks are at increased risk of heart disease, and we ought to be more aggressive with these folks to help limit their future risk of heart attack and stroke. Now, there are a lot of people out there who struggle with these cholesterol medications, also known as statins. And unfortunately, for the longest time, they were the only things available on the market. Thankfully, we do have some new medications on the market, namely Praluent and Repatha. These work in a different way than the standard statin cholesterol medications do. These are injectable medications that are injected under the skin once every 2 weeks. And these medications have effect on a special receptor on the liver. This receptor sits on the surface of the liver and ingests cholesterol so that it can be excreted in our stool. And this medication inhibits the degradation of those receptors so that they stay on the surface of our liver longer, so that they can gobble up more cholesterol and get rid of it. And these medications have shown profound reductions in LDL, often down into the teens. And you might say, well, can your cholesterol be too low? And so they've looked at this, and here there's, again, two kind of fun graphs there. The red there shows the average amount of blood cholesterol if you were on Praluent, and that showed that on average, you were looking at LDL cholesterol in the 10, 20, 30, 40s range compared to those folks who were on statins, where their average LDL cholesterol was in the 100s to 110s. And what they found out is even with these absolutely, in the toilet low LDL cholesterols, there were no difference in adverse events, meaning no problems with brain function, no problems with cognition. They did find that folks who had really low LDLs did have an increased risk of cataracts, but thankfully we've got lots of great eye surgeons who can take care of that. On the flip side, what they showed is that with those dramatic reductions in LDL down into the 10s, 20s, and 30s, we saw continued reduction in heart attacks, strokes, and cardiovascular death, supporting this idea that there really is no floor when it comes to LDL reduction. The lower, the better when it comes to heart health. All right, what about other screening? I want to take a minute to talk a little bit about what's called, well, I wanted to call attention for those folks who may still be kind of unsure about what they should do. For the first time in the 2018 guidelines, it said if there was any question at all about whether cholesterol medication should be started, they should consider this test called a coronary calcium score. Okay, I've included some illustrative images down here below, and what you can see is some cross-sectional images through the heart. That big circle guy in the middle, that's your aorta, and you can see a little blood vessel coming off on the right of that. That's the left main and left anterior descending coronary artery. That's the artery that comes down the front side of your heart. And you can see some bright stuff there, right? That's calcium. That's hard plaque that's developed within the heart arteries. And the presence of that is 100% specific for coronary disease. If there's calcium, you have heart disease, right? And what they've done is they've taken this calcium score and they looked at a big study, 17,000 patients with no history of heart disease. And what they did is they did a calcium score. And if the calcium score was, higher than 1, then they looked at the effect of cholesterol medications. And they followed these folks for, on average, almost 10 years. And what you can see on this graph, you've got blue lines on top, red lines on the bottom. What the red lines on the bottom represent are these are folks who had a calcium score of 0. And they looked at people who took a cholesterol medication or didn't take a cholesterol medication. And they looked at whether that had any effect on future risk of heart attacks or strokes. And guess what? No difference, right? If you had a score of 0, there was no benefit of being on a cholesterol medication. Now, the top lines, the two blue lines, this is any score above 0. If you've got a score of 1 to 1,000,000, you can see that there was benefit for being on a cholesterol medication. Specifically for those folks that had a calcium score above 100, they saw a 54% reduction in risk of heart attacks, strokes, and cardiovascular death over the next 10 years. If I could tell you that there was something that, a magic pill that would reduce your risk of heart attack by 50%, I think I'd have a line around the block to take that pill. All right, there are other things that we can do to take a look at it. This is a representative image of a coronary angiogram. This is an invasive study where we bring a catheter up into the inside of the heart and inject some X-ray dye into the arteries themselves. We take a look at these arteries in real time and we look at any narrowings. Here you can see there's a narrowing in the proximal segment of that vessel. And this, thankfully, right then and there can often be treated with a stent, which is a metal scaffold. When mounted onto a balloon and blown up, it pushes all of that blockage to the side. This is, of course, an invasive test, right? And it comes with associated risk, and so we don't do this test unless there's good reason. There's also a fairly new piece of technology, and that's what's called a cardiac CT. And I want to preface this. Ultimately, the quality of any X-ray image is dependent upon the subject staying still, right? If I'm moving around while they're trying to take my picture, you're going to get a blurry image. Well, the same is true with these CAT scans. Unfortunately, the heart never holds still. In fact, if the heart holds still, you got a totally different problem, right? And so in order to get past this, we use medications to slow the heart rate down, and we use some technology to sync the heart rate up to the CAT scan machine so that we can take pictures during specific times of the cardiac cycle. And with that, we can make reconstructed images of the heart arteries themselves. And we can see that these plaques within the arteries are a whole lot more complex than what they show up on when we do an angiogram. You can see there's elements of soft plaque and hard plaque, and plaque that moves outside of the vessel and plaque that moves inside of the vessel. And they've done some big studies in using this cardiac CT to kind of figure out where it kind of fits in the management of heart disease. And ultimately, in this big study, almost 5,000 patients over there in Ireland, they looked at folks who came into the emergency department with chest pain. And they randomized them to either get a plain old stress test or to get one of these cardiac CTs. And ultimately, what they found is that if you got a cardiac CT, you had a 40% reduction in your risk of future heart attack and stroke. And you might say, well, why is that? How is just getting a CT, changing this trajectory? And you might say, oh, well, those folks who get cardiac CTs, they probably get more stents and they probably get more bypass surgery. Well, this graph here on the right shows there was no difference in revascularization, no increase in stents, no increase in bypass surgery in folks who got this CAT scan. And so you might say, well, geez, what was the difference? Well, this is where the difference comes in. If you come in with chest pain and you get a stress test, the stress test comes back as normal, and the doc says, your stress test is normal, the pain's not coming from your heart, right? We're reassured, we don't worry about our heart anymore, and we may not necessarily make any changes to our lifestyle. Now, if, however, you were to have chest pain, come in and get this scan, and that scan showed, well, you've got some blockages there, but none of them are large enough to be causing any blocked up vessels. But in that circumstance, we need to be more aggressive with your blood pressure. We're going to manage your cholesterol better. We're going to make sure that your diabetes is well taken care of. And oh, by the way, you're going to quit smoking. Now you can see the power of risk factor modification because of this increased knowledge that comes from this special CT scan. Right? The CT scan tells us more than just stenosis. It tells us about the characteristics of the plaque, its location, and the amount of muscle that might be affected should something happen. And so you can see there are lots of tools in our tool belt that we have to manage our heart. Today we've talked about non-modifiable risk factors, the things that we can't do anything about, our age, our sex, and unfortunately our relatives. And we've talked a lot about things that we can do something about, our positive habits of exercising, the diet that we keep, and avoiding chemicals into our body that might do damage to our heart. We've talked about screening that we're going to need the help of a physician to do, that of blood pressure screening, cholesterol screening, and perhaps more direct screening of the heart via one of those coronary calcium scores. And I hope that if anything, what I've done today is inspire you to maybe think one more time about your heart and think about what things you might need to change today in order to make sure that your heart's. And with that, time for some questions.
Dr. Behunin, this is Holly. Kim had to step out for a few minutes, so I will watch for questions. Sadie, will you help me watch for questions for him? That was wonderful, by the way, Dr. Behunin.
Absolutely, my pleasure.
Yes, I think our first question had to do with tobacco. So this person writes, my neighbors smoke a lot, not just cigarettes, marijuana and other illicit drugs. The smell comes over into our yard. Are there any studies on the second and third hand effects outside of the home? What are the risks for kids playing in the backyard surrounded by smokers?
Yeah, this is a fantastic question. And I find myself in a similar situation. We have some folks that live behind us and they come and smoke in the backyard, and it really gives me pause about allowing my children to play in our backyard. There have been lots of studies that have looked at the risk of secondhand smoke, and while the direct risk is not as high as those folks who are, smoking themselves, there is documented injury and prolonged effects, such as worsening of asthma that come along with exposure to secondhand smoke. There's not as much research at looking at, exposure to fumes of marijuana. Again, just because it's been illegal for so long, there's just not as many studies there. But we know that it's bad if they're smoking it, and if we're inhaling it too, it's, while the exposure may not be as much as theirs, there's still damage being done.
Thank you. It looks like our next question. Oh, we have a lot of people asking about getting a copy of this presentation. So there should be one in the calendar invite that you were sent. There's the slides, but we'll also put it on our Healthy Lifestyles page. Let's see here. Is high blood pressure a symptom of a more serious disease or a disease of its own?
That's a great question. So I take care of folks with high blood pressure every day, and the answer is yes, right? It can be its own thing. It also can be a secondary process from other causes. And so ultimately, the way that it's typically approached is we manage, we'll start standard blood pressure medications if blood pressure has been documented and is persistently found to be elevated. And ultimately, if we find ourselves in a situation where, despite our efforts of controlling blood pressure, we're having persistently elevated values, then we dig a little bit deeper about potential what we call secondary hypertension, or hypertension that's secondary to something else. And those something else can be things like some excretory tumors from the adrenal gland that can cause high blood pressure, sometimes narrowing of the blood vessels that feed our kidneys. That can make the kidney think that the blood pressure is lower than it actually is. And the kidney needs to see blood pressure, right, so that it can clear out our blood and produce urine. And so our kidney kind of reflexively sends out chemicals in our body to increase the blood pressure so that it can see the perfusion that it needs. And so, again, the answer is yes for those folks that have blood pressure issues. We manage it with medications, and if we're not making the progress like we need, then we look into potential secondary causes.
Okay, thank you. Our next question is, how much stock should we put into changes in resting heart rate as reported by fitness trackers? If mine has increased 10 points in resting heart rate over 6 months, is that a concern?
Another great question. With the advent of all of these new devices, Apple Watch and the Samsung Watch, right, we become increasingly focused on not just our heart rate, but our heart rhythms, where those heart rates are when we're awake and when we're asleep and all over the place. Ultimately, the normal range for heart rate is anywhere between 60 and 100, right? If you come into my clinic and your heart rate's 90 and you feel fine, then I don't make too big a deal about it. There have been, now the flip side of that is you might, for folks who are kind of extreme fitness folks, marathon runners, they often have very slow heart rates, often heart rates down into the 50s, and they feel equally as well. And there is something to be said about the lifestyle that marathon runner lives, right? The diet that they keep, the exercise that they do, and its effect on our heart rate, that those folks do live longer. Kind of supporting this idea that maybe there is a loose correlation between how fast your heart rate goes and how long you live. But unfortunately, the studies really haven't panned out on that. But ultimately, what it comes down to is really we should be exercising more, working on our weight to keep that down into a healthy range, and keeping our blood pressure where that should. And as we do those things, we will notice that our heart rate tends to be a little bit slower. But ultimately, there's no damage that occurs to the heart as a consequence of a heart rate that on average is in the 90s.
Okay, we got quite a few more. The next one is, would you recommend a CT scan as a preventative measure and a review if you have had a stent put in the last few years?
Great question. So these coronary calcium scores are a fantastic a fantastic screening exam to look for underlying heart disease. There is nothing that, there's the phrase, a picture speaks 1,000 words. There's nothing that motivates more than being able to see your own heart and see the plaque that's there. With that being said, if you have an established diagnosis of coronary artery disease and prior stent placement, a calcium score is not necessarily going to add any additional information. In fact, that stent shows up equally as bright on a calcium score and will falsely elevate the score itself. And so if you have a history of coronary disease and stent placement, a coronary calcium score is not going to be a good test for you. But if you are in that boat, previous stent, and having chest symptoms, a visit with a cardiologist is definitely warranted. For those folks who may have cardiac risk factors, a family history of heart disease, but don't have any known history themselves, a coronary calcium score is a great way to kind of start a discussion about heart health. We've got a great program here at St. Mark's for these coronary calcium scores. They're available at a cash price of $69, which is a steal. And that's the flat cost. There's no bill to insurance, no other copay. And ultimately what that entails is the scan itself and a mailed report to your home detailing the calcium distribution and where that compares to other folks of similar age, sex, and race. I read all of those scans here at St. Mark's. And if there are high-risk scans, then I take that opportunity to reach out to those patients individually so that we can have a conversation and hopefully adjust the trajectory of their heart health in the future.
And this next question has to do with menopause. Does menopause increase blood pressure? What can we do?
Absolutely. Another great one. So for those ladies out there, there's no doubt that menopause is a big change. And ultimately, there are pretty wide swings in hormone changes that come with all sorts of symptoms associated with it. It can have effect on blood pressure. And ultimately, it's going to take a little while for things to settle out. And so it can be a little bit of a challenge there at the beginning. I should say it can affect blood pressure both up and down. And so, again, it just takes a little bit of tenacity and monitoring with a home blood pressure cuff to kind of see what average blood pressure is. Because ultimately, that's what we care about. We care about average resting blood pressure. We know that blood pressure is going to go up and down depending upon the circumstance, how much salt you ate, the stress that you're under. And so we worry less about those peaks and less about the valleys and more so about what blood pressure is on average.
Excellent. And does an AFib patient benefit from a pacemaker?
Good question. We didn't really talk much about atrial fibrillation during our presentation today. Ultimately, I would say no, at least not if your cardiologist is doing their job. So if you have atrial fibrillation, perhaps I should back up. So under normal circumstance, our heartbeat initiates up in the top right of our heart. It sends an electrical signal down to the bottom of our heart such that it beats in sequence. In atrial fibrillation, however, there are hundreds of chaotic signals that are all originating from the top chamber, such that the top chamber is quivering. It's sending all of those electrical signals down to the bottom such that it beats fast and irregular. This fast and irregular heartbeat comes with two consequences. If the heart beats too fast for too long, it can weaken the heart and cause congestive heart failure. And because of that quivering top chamber, you get stagnation of blood in the top, and that can allow clots to form. Those clots can then leave the heart and go north and cause a stroke or elsewhere and cause damage. And so we use medications to help reduce the risk from those things. Specifically, we use medications to slow the heart rate down to prevent it from going too fast. Usually that can be accomplished with medications like metoprolol or diltiazem. Oftentimes, that's not enough to control it, and we may use anti-arrhythmia medications to suppress atrial fibrillation and maintain normal rhythm. If, despite our efforts of controlling the heart rate or the rhythm, if we're still having troubles, then in rare circumstances we consider a pacemaker. What a pacemaker is a little battery pack that gets implanted underneath the collarbone. It has two wires that come into the inside of the heart. The responsibility of those wires is first to sense if there's a heartbeat. If there is, then the pacemaker does nothing. If the heart rate is too slow, then a pacemaker will create a heartbeat. And you might say, well, how does a pacemaker go along with atrial fibrillation? Atrial fibrillation are fast heartbeats. In some rare circumstances, we can't get control of the atrial fibrillation. And so what we do is we disrupt the communication between the top chamber and the bottom chamber, right? That way, all of those AFib signals can't get down to the bottom and create irregular, chaotic heartbeats. In that circumstance, we put in a pacemaker down to the bottom to create a heartbeat down below, all right? That way we don't have the fast heart rates, but we still have the slow, regular heartbeat created by the pacemaker. And so that's really the only circumstance that a pacemaker is needed in the setting of atrial fibrillation. Otherwise, there really is no therapeutic benefit of having a pacemaker. It doesn't prevent atrial fibrillation from occurring. It just can help raise the heartbeat if the heart rate's too slow.
Okay, and it looks like the next question is for me. So we have actually collaborated with OC Tanner on this workshop. So many of the employees are from OC Tanner, while the other half is from Salt Lake County. So this person's asking how I access healthy lifestyles. That is Salt Lake County's employee wellness program. So if you are a Salt Lake County employee, chat with me separately and we can get you set up. But if not, there's a different program for OC Tanner. Anywho, we'll move on. This person asks, is it okay to take low dose of CBD oil for achy joints? I have high blood pressure and high cholesterol, both under control with medication. Plus, I have had AFib.
Yeah, absolutely. In fact, on my one slide, CBD oil has been shown to help for exactly that. You know, there are some anti-inflammatory effects with CBD oil that certainly have helped a number of my patients to increase their mobility. There has been some reported effects that it can cause a little bit of dilation of blood vessels, and so that might actually even lead to a slight decrease in your blood pressure. But ultimately, there's no effect on cholesterol. And so what they found is that it looks like CBD oil is in fact safe for folks that have heart disease, troubles with cholesterol and blood pressure. The one caveat there would be is that there may be trace contaminants of THC in this CBD oil, and that might trigger positive on a urine toxicology screen.
Oh, thank you so much for answering all of these questions. I don't want to take any more of your time, Doctor, but it looks we have a couple of more questions, but we do have a stop at 1 o'clock. Would these people be able to email you?
That's a bit of a challenge. My email kind of is an abyss sometimes. And so probably if there are, for Kim, is Kim available?
I'm sorry, no, she's not.
She's not. Okay. I was thinking if there would be, if there's these folks signed up through an email, if there was a way that they could, we could kind of compile some of those questions and perhaps add a Q&A to the website to answer some of these more direct questions.
That's a great idea, Sadie. If you want to compile the questions, we can send them to Kim and get back to them.
Excellent. I will do that.
I would just like to say something. I would appreciate the write-up, what you said, because I forgot about it and came in late.
Yeah, from what I understand, I think that the copies of the slides themselves were sent in the invite to this meeting today. And beyond that, I think it was recorded, and so it should be available for re-review later.
Great.
This is Nathan. Yeah, we recorded this, so we'll send out the link if you want to watch it again.
And of course, if you have any questions about your heart, I would be happy to see you here in clinic. You've got my contact details there here at the Heart Center at St. Mark's. And I'd be happy to talk to you about heart health and how to keep you away from a heart attack.
Thank you very much, Dr. Behunin.
It's been my pleasure.
Thank you so much. Everyone enjoy the rest of your day.